This is Dr. Emily Tejani. She is a psychiatrist who is board certified not only in child and adolescent psychiatry, but also adult psychiatry and addiction medicine. Serves on the clinical faculty here in the Department of Psychiatry at UCSF. She works as part of the UCSF Youth Outpatient Substance Abuse Disorder Program and as a consultant for SAMHSA. And so with that, I'm going to turn this over to Dr. Tejani.
Hi, everyone. Thanks for joining us today, and thanks for having me here. I'm going to be talking about adolescent alcohol use disorder, but also substance use disorders more generally. While there are many different specific SUDs, the symptoms and treatment approach is largely shared for the variety of different SUDs out there. So most of what I say about alcohol use disorder will be applicable to other types of substance use disorders, such as cannabis use or opioid use disorder. The goal today is to help everyone feel more comfortable and capable in screening youth for SUDs and making diagnoses when indicated, to feel well equipped to make appropriate referrals to specialty care when needed, to perhaps even initiate treatment for certain SUDs in your own clinic, and to support not only youth in treatment, but also provide support and guidance to parents of adolescents and young adults who have an SUD or are at risk of SUDs. Next slide. I want to start by pointing out what may or may not be obvious, which is really that substance use disorders are pediatric onset disorders. The vast majority of adults with an SUD had the onset of that disorder during adolescence or at the latest, really early adulthood. Substance use disorders can also be thought of as developmental disorders, by which I mean there are discrete risk and protective factors at play at every step along the developmental trajectory from preconception into adulthood. It's also really essential when working with youth who have substance use disorders to recognize that the vast majority of individuals with an SUD also have a co-occurring psychiatric disorder, and often more than one co-occurring psychiatric disorder. About 50% of teens with an SUD will have 3 or more psychiatric diagnoses. The most common psychiatric diagnoses that co-occur with these disorders include ADHD, ODD or conduct disorder, post-traumatic stress disorder, mood disorders, both major depressive disorder and bipolar disorder, and personality disorders. Commonly, borderline personality disorder is something we see in this population. Next slide, please. Here is my plug to get everyone interested and involved in doing addiction prevention and treatment, because there aren't nearly enough specialists or specialty clinics to meet the need. Can you press next slide? There's a little, there we go. So as you can see here, the overwhelming majority, nearly every young person with an SUD is not able to get treatment for that SUD. And you can see things aren't getting any better. I don't have the last 10 years on this slide, but it would be about the same, where 90 to 95% of youth diagnosed with an SUD receive no treatment. And there are many more youth who have an SUD who have not even received a diagnosis. So it's really, kind of a dire landscape right now. And by getting primary care doctors and behavioral health clinicians and using a multidisciplinary approach to prevention and treatment, we can help many more people and change these young people's trajectories. Next slide. I'm going to just briefly touch upon some of the epidemiology and the temporal trends in youth substance use and with a focus on alcohol use disorder. So In the last 5 years, 5 to 10 years, we have really seen a steady decline in the rate at which middle schoolers and high schoolers use drugs or alcohol. It's really a historic low, lower rates of past year and past month substance use and alcohol use compared to what we had seen in the 70s, 80s, 90s, even around the turn of the century. The rate at which specific substances are used amongst young people and older people tends to vary over time. And it's probably not a surprise to hear that certain drugs kind of come in and out of popularity. What we've seen with youth over the past 20 years or so is that alcohol use, both past year use and binge drinking, has really declined markedly. The last few years, we're sort of seeing a leveling off, so we're not sure if that decline will continue, but we've made a lot of progress toward seeing lower rates of youth using alcohol and using it in harmful ways. When it comes to most other substances, we have also seen a decline, not as dramatic as what we've seen with alcohol. The one exception really being cannabis use. Cannabis use rose steadily from the early 80s until about 10 years ago, and it's been fairly level since then, but we continue to see increases in daily marijuana use, especially amongst young adults, college-age students. So there's a higher intensity or frequency of marijuana use than what we've seen before. Next slide. We're not going to have time to get into all the different factors that influence these epidemiologic trends, but a couple important ones that have been well validated in the literature include drug availability. The easier it is to get a drug, the higher the rate of use is in any given population. That's pretty much a universal truth. And so it's no surprise that alcohol, which is one of the few legal psychoactive drugs, is the substance that both young and older people use more often than any other substance. And it's also the SUD that is the most common reason that one presents for addiction treatment. Another important factor here is perceived risk. The level of risk that is associated with use of a specific substance is inversely correlated with rates of use. And we see sort of generational trends in which certain drugs are perceived as more harmful than others, and the rate of use of that drug tends to drop in the population until reaching a point where the perceived risk is lower than it was previously. Next slide. Okay, so I'm going to focus in on alcohol a little bit here. And since alcohol is one of the few legal substances and also the substance most commonly used by young people and older people, I think it's important to point out that there are some very real and potentially long-lasting harms of alcohol use, really at any point in a person's life. But there are some unique harms that likely exist with adolescent alcohol use. And this is probably because there's a lot of important brain development happening during those adolescent years that's really happening in the areas of the brain that are affected by alcohol, and the areas of the brain that can help protect a person from developing an addiction are undergoing a lot of remodeling and change, synaptic pruning during these years. And I think it's commonly, at times there's a perception that it's inevitable that young people will use alcohol and that it's sort of like a normal part of development. But really it is a part of one's development when, if present, can cause harm and can change one's entire trajectory, both behaviorally and cognitively. This graph here is from a recent study from the ABCD, Adolescent Brain and Cognitive Development group. It's a powerful cohort study that's been following kids for decades. We'll be following them into adulthood, taking all sorts of behavioral and psychiatric measures, and also doing a lot of brain imaging along the way. And they just published a study looking at alcohol use between the ages of 14 and 16, and the level of impulsivity that an individual displays at different time points. And that they found for people who used low to moderate, like less than 40 uses of alcohol during that period, the impulsivity measures slowly declined as the person got older, which is what we expect as the prefrontal cortex of the brain matures. But we saw a very distinct difference in the group of youth who used alcohol more heavily, which was defined as more than 40 occasions. In that group, not only was there not a decline in impulsive behavior, there was actually an increase. So we saw the opposite of what we expect developmentally to occur. And this was also found in another study that sort of looked at the brain centers involved in impulsivity and found some very discrete changes in those regions of the brain in the individuals who used alcohol more heavily. And since they controlled based on baseline impulsivity, it does suggest that the alcohol use itself and not just some confounder or common factor is involved in this trend toward greater impulsivity with more pre-adolescent and adolescent alcohol use. Next slide. Just briefly, since we are in the midst of a pandemic, unfortunately still, I thought I would share with you the data we have so far about how youth substance use patterns have changed since the start of the COVID-19 pandemic. While we still are early in gathering this information and there are some conflicting data sets out there, this study that was just recently published is a pretty large one, and it tracked past 30-day substance use habits amongst adolescents between I think it was April and September, a 6-month period early in the pandemic when largely people were under lockdowns or shelter-in-place orders. And what they found is that rates of past month use really didn't significantly change. It looks a little significant there, but it wasn't. But the type of substances that young people were using did change. We saw less alcohol use, but more nicotine and prescription drug use. There was no significant change in rates of cannabis use. And we don't know exactly why this is, but I suspect it has something to do with availability because supply and demand can be tightly correlated when it comes to substances. The other thing that this study found that I think can be helpful to keep in mind when working with youth in this time that we're in is that there were 4 distinct risk factors that were associated with greater periods of substance use. One being stress related to the pandemic, the uncertainty of the pandemic. They specifically asked about stress due to getting COVID versus stress due to the uncertainty of life. And they found that worries about COVID itself didn't seem to precipitate increased use, but that stress related to sort of what's next in life because of this pandemic, that was a risk factor and a trigger for more use. Family economic hardship was another risk factor, having greater depressive or anxiety symptoms, and then being at home with parents who used alcohol or drugs was also a precipitating factor for greater use. Next slide, please. All right, I'm going to shift a little bit into some more practical information about what to do when a patient shows up in your clinic who may be in need of a screen or intervention for an alcohol use or substance use disorder. I imagine many of you screen regularly for SUDs. I know that we've done as a country a lot of education on the importance of screening in the SBIRT model, and I assume many of you are probably familiar with that and probably implement that in your own clinics. So I'll kind of go quickly through this. Screens, as you know, are not a diagnostic tool, but they are a quick and valid way to differentiate higher risk versus lower risk groups, and then to provide intervention and referrals as needed for that higher risk group. The American Academy of Pediatrics and SAMHSA recommend that pediatricians screen all adolescent patients annually using a validated screening tool. A lot of the tools have been developed for populations age 12 and up, but there are some tools that can be used with youth as young as 9 years old. And really, the American Academy of Addiction Psychiatry recommends starting substance use screening and prevention with this younger age group before the onset of middle school. Next slide. In addition, you may want to consider screening youth who are coming in for a condition that's associated with an increased risk of having or developing an SUD. So youth that come in with chief complaints related to depression, anxiety, or ADHD. It often will be appropriate to do a substance use screen with those youth when youth are coming in with chief complaints that may be secondary to the use of alcohol or other substances, such as sexually transmitted infections, accidents, injury, GI issues, pain, sleep problems, or if someone's coming in with a significant change in their behavior or their functioning. Those are all situations in which it would be appropriate to do a screen, even if you've already done one at the youth's annual visit. Next slide, please. I've listed here the most commonly used screens. These are all validated for use in adolescent populations. What I find is that most people seem to do craft. I think that's something that's taught largely in medical school and residency curricula, and it's a great screen. It's also more than a screen. It's actually a brief assessment tool. So craft goes a step further than these other screens and helps assess for level of impairment, not just level of risky use. The S2BI and the BSTAD are great in that they can be administered electronically. They assess for all types of substances, and they're pretty thorough. The NIH or NIAAA alcohol screener is less commonly known and used, but I really like it because it's very simple. It's 2 questions that can be easily added into any sort of intake or interview. You can kind of adapt it to your own style and rapport with the patient. And it has been validated in younger populations down to age 9. So it's likely to pick up kids a little earlier who are high risk, and then allow us to deliver earlier intervention, which may be more effective. Next slide. Okay, this is just a picture of the NIAAA screen. As you can see, all it is asking, do you have any friends that drink? Do you drink? And if they say yes, on how many days in the past year have you drank? And then you can access this algorithm on their website or print it out. And the cool thing is, next slide. They really do a nice job of sort of, breaking down these different risk levels, not only based on how much the person drinks, but based on the age of the person as well. And I'm sure as pediatricians, you can appreciate like how important it is to, take development into account. And there really is a difference between a 10-year-old who's drinking 5 times in the past year versus an 18-year-old. And so that's a different risk category. Next slide. Okay, moving a little bit into what is done after the screening process. I want to talk in ESPERT in a little bit of detail here. I think you're probably all familiar with the basic protocol. You may have seen the paper published, I think it was last year. I'm not sure if it was in Pediatrics or in the Public Health Journal, but that kind of said we don't have enough evidence to support screening adolescents. And I want to caution you from shying away from continuing your ESPERT, because if you have a chance to read the fine print in that paper, essentially the the finding was that there are so many different types of interventions being offered. There's such variability in the way that SBIRT is delivered that it was difficult to find like a signal or have consistent enough data to really draw conclusions, and that the studies to date have not been designed to look for potential harm, which is an important thing to evaluate for in order to weigh the harm versus benefit ratio. And there are certain approaches that clearly show benefit, that show better outcomes regarding SUDs in youth who receive SBIRT in a pediatric setting. But there is a better way to do it and a not as helpful way to do that. And so next slide, I'll talk about that just briefly here. And I guess here I should add that one thing that often gets neglected, sometimes for very real practical reasons, sometimes simply in the interest of time, is this last part, the referral to treatment. I think a lot of people are screening, a lot of people provide that guidance in the moment when we get the completed screen, which is great, but we have to remember that this last step, the referral to treatment, is really the key part of being able to affect change in that youth's trajectory and outcome. And I think the hard thing is it's not always easy to find that treatment or to know where to refer to. Next slide. So just to kind of summarize what I was getting at before, there is good evidence that having a pediatrician who's trained in SBIRT or an embedded behavioral health clinician who's trained in SBIRT delivering this to patients increases the rates of those patients entering specialty SUD care. And there's also some data out there that has looked at longer term outcomes and found that we see lower rates of not only SUDs, but lower rates of psychiatric conditions and other chronic conditions up to 3 years out when SBIRT is implemented to its fullest extent within a pediatric clinic. Next slide. And here I was just pointing out that a lot of young people and their parents want help, but they don't know where to get help. It may not even come to mind that they can talk to their pediatrician about these things. The way that our health system is set up and the things we see in movies or hear about can at times kind of suggest that doctors, primary care doctors, may not know about drug and alcohol treatment, or that you might have to go outside to get that sort of help. And we want to kind of change that mindset and make sure that our patients know where to go and that they go somewhere where they can get evidence-based information. Next slide. I want to, just briefly mention that rapport does matter, and SBIRT outcomes are better when the intervention and referral is made by the patient's primary counselor or a behavioral health clinician. I would also add a pediatrician that has a longstanding relationship with the patient would fall under this category. So, the relationship matters, and you don't minimize the effect of having a patient that knows you and that well, that can really make a difference in motivating someone to open up more about these sorts of problems and be willing to get help. It's really important to remember that there's no one-size-fits-all algorithmic approach to the intervention or even the referral to treatment portion. When we're referring a patient to treatment, we want to individualize the reason for that referral as much as possible. We want to stay focused on the patient's own goals and concerns, and we want to be as available and supportive throughout that process. Having a warm handoff as opposed to giving them a piece of paper with some phone numbers is going to be a lot more helpful. Next slide. This is just a summary. I'll let you read this later of how I might talk to a youth after receiving the results of their screen. And maybe we'll sort of come back to this as we talk about the case, but the key things to kind of think about here is that you really want to remember that you are in the interest of improving their health and well-being, and that, whatever our own opinions or ideas are about what they should or shouldn't be doing with substances, that isn't really relevant to figuring out where they're at health-wise with the substance use and what they should do about it. So we want to really just kind of summarize in their own words the good or the bad or whatever they've shared is happening, and then connect that to a referral need by letting them know that you have a colleague or there's a place where you could talk about these things more and get some more information to kind of see, how you might want to proceed. Next slide. I think sometimes as doctors, we're worried that we might condone drug use if we ask in too non-judgmental of a way about it. But it's sort of like with asking about suicide, talking about it doesn't make it more likely. If anything, talking about it helps people manage better and make better decisions about the risky or difficult things in their life. So I always ask young people, what is it you like about it? What do you find, why have you done it? What draws you to it? I'll also ask if there's any downside to using, but I think when you start from a very open, non-judgmental stance, people are likely to open up more and feel comfortable and to trust you and to follow your advice. Next slide. This one we can just kind of click through quickly. This is just a slide. There's a few animations. I know we're almost out of time. So these are some of the quotes from young people about why they're not going to treatment or are afraid to go to treatment. Some adults don't see both sides. Next slide. I wouldn't know what to say. Next slide. I'd be embarrassed. Next slide. They might be rude and punish me. So is confident and rebellious as some of our patients may seem when they come in, there's a lot of vulnerability there, and these are not easy topics to talk about. And sometimes what meets the eye isn't exactly what's going on beneath the surface. So we need to remember that these are difficult topics to discuss, and creating an environment of respect and openness really goes a long way. Next slide. These you can kind of click through to I didn't realize there were so many animations. These are quotes from young people. This was a descriptive study that asked them what was most helpful about their drug treatment. And as you can see, it's all stuff that is really based in looking at the youth's strengths, having a collaborative process where they don't feel judged and where they feel understood, and there's really an environment of empathy. Let's just summarize as what we kind of went through in the last few slides. Next slide. I know we're going to have to stop because we're out of time. I want to emphasize that SUD treatment works, and there are studies looking at adolescent treatment and finding that the outcomes are just as good as the outcomes for adult SUD treatment, with the caveat that the treatment for youth needs to be developmentally appropriate. So you don't want to send young people to an adult treatment. That's not going to best meet their needs, but we can see improvement, and we do get good outcomes similar to the outcomes we see with other chronic illnesses such as diabetes or hypertension when we provide people evidence-based care. Next slide. This is a list of the evidence-based treatments. There's really just one last slide I wanted to comment on real quick. If you could just click through, please, Joan. This is a list of medications that have been investigated in youth. I can answer questions about that later. And then the last two things I want just briefly touch upon here. Here's something, how do you get the youth who says they don't need or want treatment to go to treatment? We can talk about that as we go through the case today, because this is a common difficulty. It's almost universal that the parent makes the appointment. Rarely does the young person call and tell you they want to stop using X, Y, or Z. And a lot of times parents are already feeling kind of defeated. They commonly say things like, doesn't my kid first have to want to change before they can change? And I want to be very clear that the answer to that is no. The first step in the treatment is developing that motivation to change. We know that motivation is malleable, and a big part of our role initially is to get people to reflect more and move along the stages of change. That's an important part of treatment. It's not a failure to not be there already. Next slide. We can just scroll through this. This is kind of what we already talked about. Next slide. And then lastly, There's a very important role for parents here, and it's wonderful to allow adolescents confidentiality and autonomy in their treatment, but we don't want to forget that there's very strong data that SUD treatment that is family-based is more effective, much more effective than treatment that is not family-based. And parents are really a huge resource, a partner in the treatment of these disorders. And there's lots of good studies out there to guide us and guiding parents on how they can support their young person at home to increase the chance that they will go to treatment and that they will reduce their use. And there's an intervention called community reinforcement and family training, which is developed specifically for family members, parents, or loved ones of people who have an SUD. And it's sort of like a cognitive behavioral therapy approach that is much more effective than the old-fashioned sort of big interventions or sending a parent to Al-Anon and getting young people to go to treatment and stay in treatment. These studies have been in adolescents as well as adults. And I think we can stop there so that we have time to go into the case.
Fantastic. Thank you so much for sharing today.